Hello everyone, today we're going to be talking about mesenteric ischemia. Mesenteric ischemia is caused by an occlusion of blood flow or decreased blood flow in the mesenteric vessels, resulting in bowel ischemia or even infarction. There are several high-yield history and physical exam points to be on the lookout for in patients with mesenteric ischemia. These patients may present with acute onset abdominal pain that's poorly localizable. It's often described as pain out of proportion to physical exam, and on test questions and in the real world, you may even be asked to decide between patients who are malingering and patients who have pain that is different from what the physical exam is showing you. You'll also want to ask about nausea and vomiting and diarrhea because these are often present in mesenteric ischemia. Finally, on history, you'll want to assess for important risk factors in the patient's past medical history. AFib, peripheral vascular disease, coronary artery disease, valvular heart disease, and AAA all point to different types and different etiologies of mesenteric ischemia. On physical exam, you will want to look for hypotension. Hypotension itself can be a cause of mesenteric ischemia because the mesenteric vessels just aren't delivering enough blood to the bowel. Next is the physical exam side of the pain out of proportion. These patients will be in tons of pain lying in bed, often described as writhing in pain, but the pain is not worse with physical exam, and it's tough to actually get where these patients are hurting on the physical exam. That is, unless they have peritoneal signs, in which case they'll have rigidity and guarding. These patients might also have positive fecal blood because they have sloughing of dead bowel. Finally, you'll want to assess for risk factors here too. These patients, if they have AFib that's uncontrolled, will have an irregular pulse. They have valvular heart disease. You might see murmurs, and you might see signs of peripheral vascular disease on a skin or lower extremity exam. The differential diagnosis for mesenteric ischemia includes infectious colitis, IBD, diverticulitis, radiation enteritis, C. diff, cholecystitis, bowel perf, nephrolithiasis, small bowel obstruction, complicated UTIs like pyelonephritis, and MI. I've attached this diagram from Clinical Problem Solvers, and I think it's really good. They have an app. It's catered more towards internal medicine, but they do a really good job at helping and teaching you build your differentials. So after you build that good differential, you're going to want to order your diagnostic tests accordingly. Labs that you'll commonly get to work up mesenteric ischemia include a CBC, BMP, LFTs, lipase. Lactate is really important here because that tells you if there's any hypoperfusion. LDH, phosphate, CPK. Amylase is also a common one that you'll see if you're starting to have intestinal problems like intestinal rupture. Coags and troponin if you think that these patients might have risk factors for an MI. Also, if you're going to get a troponin, you probably need to get an EKG also so that you can thoroughly rule out MI. For imaging, you're going to want to get a KUB because this will rapidly be able to tell you if they have any air under their diaphragm and might also give you indications if they have a small bowel obstruction. CT with oral and IV contrast is really important because it will help you visualize the bowel wall and see if there's any blockages in the arteries or veins. If your CT is equivocal, but you still have high clinical suspicion for mesenteric ischemia, you should definitely consider angiography and talk with your surgical team about whether or not they think this is a good idea. After you diagnose mesenteric ischemia, you're going to want to get an emergent surgical consult. These patients most likely will need vascular surgery or some sort of endovascular procedure, and patients with peritoneal signs may require an exploratory laparotomy to see what the cause of those signs are. Your job in the emergency department is to correct and address the underlying causes. If your patient is hypotensive or has hypovolemia, you'll want to start fluid resuscitation, most likely with lactated ringers, and you may need to add on pressors. But be careful to avoid alpha agonists like phenylephrine because they'll only make the problem worse by causing more peripheral vasoconstriction. If you suspect an embolic source and suspect atrial fibrillation as the cause of that source, you'll want to control that arrhythmia. Finally, we'll address what's called low flow states, which is similar to hypotension, but likely due to vasoconstricting meds causing reduced blood flow even at a euvolemic state. Next, you'll want to put in an NG tube and make the patient MPO. This is not only because they're likely going to surgery, but for enteral decompression. Next, you'll want to start broad-spectrum antibiotics to cover gut flora. Zosyn or a third-generation cephalosporin plus metronidazole are good options that give you broad coverage here. Finally, if you suspect embolic or thrombotic ischemia, You should consider systemic anticoagulation with heparin. Heparin's pretty easily reversible, so this is a good option in these patients if they're going to surgery. Last, something you can consider is IR angiography or catheter-directed antithrombotic therapy if your patients aren't good surgical candidates or may have to wait a while before they can undergo definitive management. The disposition for these patients is pretty straightforward. The decision will most likely be made by surgery, and they're probably headed to the OR. Now it's time for some fast facts and practice pearls about mesenteric ischemia. We're going to discuss common etiologies, pathogenesis, and risk factors for different types of mesenteric ischemia. The most common type is arterial embolus, which is caused by an emboli from the heart being lodged in a peripheral vessel, in this case, the mesenteric vessels. Risk factors here are AFib, PCI in patients with coronary artery disease, and valvular disease. Next up is thrombus. The pathogenesis here is just like the thrombus you've been taught about, where they have an atherosclerotic plaque that ruptures. So the risk factor here is atherosclerosis. Non-occlusive etiologies include mesenteric vasoconstriction and low flow states. So risk factors here are hypotension or hypovolemic shock and vasoconstrictors. It's important not to just remember iatrogenic causes like pressors, but also drugs like cocaine can cause this type of mesenteric ischemia. The least common etiology is venous thrombosis, where these patients have relative venous stasis caused by any number of states, most likely in Virchow's triad. So you're thinking about hypercoagulable states, inflammatory states, but also things like trauma and polycythemia vera. In mesenteric ischemia, like any ischemic pathology, it's always important to remember that time is intestine. Just like with stroke, you've been taught time is brain, the same principle applies here. I know this review seems pretty short, but this is a really serious thing and has a really high mortality, so you need to take it seriously from the door. These are the resources that I used when learning more about mesenteric ischemia, and I think they would be a great place to start if you want to learn a little bit more also. As always, thanks for listening.